esteemed colleagues. So I just gotta just accept this moment. Okay.
I have to go to work on Monday.
Now, I could start the speech by listing his impressive credentials or by giving the Webster's Dictionary definition of oncologist, but how often do you get to do a type 5 about your oncologist for a crowd who actually understands what you're talking about? When I was first diagnosed with osteosarcoma in September of 2018, my first question for Dr. Fetterman was, can I still go to Coachella in April? It's kind of non-refundable, and I booked all these plane tickets, and to my surprise, he said yes. And from that moment on, I just knew that we'd have a great patient-provider relationship, and boy, was I right. Dr. Fetterman is lucky enough to receive urgent notifications like, can I get my ears pierced? My mom and I are on our fuck shit, and I want to get my doubles, meaning my double piercings, as well as videos of me and another legally aged patient of his drunk in Vegas while singing Living on a Prayer.
True.
It is true. It's very true. I have the video proof. Like 11 p.m. too. I'm sorry if I bothered you. Although we always had a great relationship, my mom associated my cancer, my apologies, with his presence at first. She would say Fetterman, like Newman from Seinfeld. And for the younger members of the audience who don't get that joke, he would say Fetterman, like Dinkelberg from The Fairly Odd Parents. However, she now adores and respects him as much as I do. I'm grateful that Dr. Fetterman and his team are in my corner. Their professionalism, kindness, and quick thinking always impress me. Even when high-dose steroids transform me from a kind and patient, into a just irritable, antsy, curmudgeonly, vibrating chihuahua, Dr. Fetterman and his team still visited me at length, even with their busy schedules. Dr. Fetterman is the director of the Pediatric Bone and Soft Tissue Program at UCLA, part of the UCLA Sarcoma Program, and UCLA's Johnson Comprehensive Cancer Center. Dr. Fetterman specializes in treating children, adolescents, and young adults with these aggressive cancers. He runs an incredibly comprehensive and multidisciplinary program involving pediatric and medical oncologists, radiation oncologists, orthopedic oncology surgeons, musculoskeletal radiologists and pathologists, nuclear medicine specialists, physical therapists, and prosthetic specialists. What a mouthful. Dr. Fetterman also specializes in conducting clinical trials and leads an experienced clinical research team devoted to providing access to clinical trials for children with refractory, recurrent, and metastatic bone cancers. On top of being a great doctor, there's nothing Dr. Fetterman enjoys more than spending time with his kids, surfing, dark liquor, and playing Russian roulette with his patients' kidneys. Not to get too sappy, but in all seriousness, Noah, you've had my leg, my lungs, my scapula, my T7, and my sacrum. But you also have my thankfully unremarkable heart. And while I hope that all of your scans say that your heart is unremarkable, we all know that to us, it is remarkable. Everyone, please give a warm MIB welcome to my oncologist and friend, Dr. Noah Fetterman.
Well, that doesn't happen all the time. I thought it was going to be worse, Mia. I was sort of prepared to take a couple-week vacation and just lie low. Mia is special, and like all of our osteosarcoma patients, leave an indelible mark as oncologists and as people, and that's why when I go home every night, I have a scotch and tell my kids not to bother me, and and here we are. Before I introduce our esteemed panelists, I want to say thank you to the organizers of MIB, and especially Dr. Trucco and Christina Toma for inviting me, and the Sandino family, and the Holmes family. There are just so many people. We've all been not willing family members, but necessary family members. And I think we're all here to hopefully change the outcome for metastatic refractory recurrent osteosarcoma, that really survival is the rule and not the exception. So with that, we're going to get going to something completely different than we did this morning, and I'd like to introduce our panelists. We're going to start with Dr. Christina Baker. She's a pediatric psychologist at Rady Children's Hospital in UCSD. She's going to be talking about supporting patients and parents through diagnosis and treatment. She's a pediatric psychologist in hematology oncology at Rady Children's, San Diego. She assists children, teens, young adults, and their families in assessment to diagnosis and through treatment. Clinically, Dr. Baker focuses on age-appropriate communication of health-related information, effective and behavioral concern monitoring, education, and coaching on adaptive cognitive behavioral coping strategies. Next, we'll have Dr. Michelle Sexton, who'll be joining us virtually, and she is a naturopathic doctor at UCSD. She'll be talking about management of cancer symptoms and treatment with cannabis and cannabinoids. Like I said, she's a naturopathic doctor, which is a little different for us. Her NIH-funded predoctoral and postdoctoral research is on the topic of cannabinoids, specifically in their roles in neuroinflammation and neurodegeneration. And she has continued that research into health effects of cannabis at UCSD, affiliated with the Center for Integrative Health at UCSD. And that's really where her clinical practice and research is focused. After that, we'll hear from Dr. Janelle Fulbrecht. She's a clinical psychologist at City of Hope in Los Angeles. And she'll be talking about social and emotional care of adolescents and young adults. Dr. Fulbrecht has a lot of experience, over 2 decades of experience working with pediatric, adolescent, and young adult oncology and hematology patients and their families at City of Hope and elsewhere. And her efforts have really provided exceptional compassionate care for this AYA group and development of the AYA program at City of Hope. And last, we'll hear from Dr. Liesl Schweers, who is a clinical social worker at Children's Hospital Los Angeles, and she'll be guiding us through survivorship and that transition that is so critical for our osteosarcoma patients. She's a clinical social worker for the Life Cancer Survivorship Program and Transition Service at the Cancer and Blood Disease Institute at CHLA, and her clinical interests include the incorporation of mindfulness-based practices into psychosocial care of cancer survivors, healthcare transitions, and teaching advocacy skills. So with that, I will hand it over to Dr. Baker.
All right, we'll try this again. Good afternoon. I'm going to be talking today about best practices for supporting patients and parents through diagnosis and treatment. Let's see if we can get you the new slides. Uh-oh, sorry guys, there's going to be a couple of things there. Okay, in the quick 10 minutes that I have, I'll do my best to describe how to know how to best help patients by utilizing a developmentally appropriate approach, adaptive coping strategies for patients, and how we can best support our parents as well through this journey. So oftentimes we hear this term thrown around, do things in a developmentally appropriate manner, and I wanted to take a quick second to kind of talk about what that actually means. So a developmental approach is the use of foundational knowledge of where the child is at in terms of their physical, emotional, and social development. And we use these to communicate and support them. When we use this approach, we speak their language, right? They'll feel heard, understood, and likely to accept the support that can actually help them. I'm a child of the 90s, so I'm using note cards and this pointer, so bear with me for a quick second. All right. So let's start with the little. So these are kids ages 3 to 6. So at this time, they are pretty egocentric. So they're at the center of their own universe. This is totally normal, natural, and okay, unless they're still pulling this when they're in their 30s. Their thought processes are influenced by this, and they can be causal and associative. You may hear things like cancer is my fault, or cancer is a punishment for X, Y, Z. We also think about Piaget's pre-operational stage, where symbolic thinking, which is like pretend play, can be greater than their actual cognitive operations. So for example, if the pump's going off in their room, they may be like, oh, the pump's talking to me, versus your line's included and we need to press the button for the nurse's help. Another thing to consider is that time is out the window. They don't have a very good conception of time. So 5 minutes can feel like 5 days and vice versa. And then family at this stage is our core social interaction. So we want to be thinking about the impact of prolonged separation from our family unit. And we also want to think about how we can support them in that. So you might see kids at the hospital quite commonly with things like a blankie, a transitional object that helps them from space to space. Okay, so school-age kids, so this is where around 6 to 13 years old. So at this point, kids should be becoming more logical, believe it or not. They're moving away from more of that egocentrism to being able to see others' viewpoints and understand that. There's a better understanding at this stage of simple functional explanations of their treatment, their diagnosis, what they're going through. Pediatric cancer having no cause will be upsetting for them. So we want to be thinking about Kohlberg's stages of moral development, where nature's not following the rules. Some kids are going to have a really hard time with that. And then at this stage, friends are our core socialization. So separation from school and sports can be extra challenging. We want to understand the importance of this because we might be thinking other things are important at this time. And now everybody's favorite, teenagers. So there's a lot of common issues that teenagers are going through before they even start this journey. Those will be things like identity, independence, and intimacy. They're beginning to have more abstract thought. So they can start to understand maybe the complexity of their diagnosis and what they're going through, but at this stage, we don't always have the distress tolerance to be able to cope with that understanding. At this stage, they might have just been feeling real good and independent, getting out of the house a little bit more, and they may have to transition back to the dependence of their parents, and that can be a real challenge as well. Physical appearance, this is something that can be really important to teenagers, and so we want to be mindful of how impactful it may be to lose our hair, to lose some weight, to have scars. And then there's also this tendency to begin future thinking. And so impacts of things like chemo on infertility may be present in their mind. So with consideration of these approaches, I wanted to segue into the mental health stages for all, the mental health for all the stages. With cancer and treatment, such a distressing event, I'm sure it comes as no surprise that anxiety and depression is a risk for this population. Things like anxiety to diagnosis and treatment or disruption of daily activities. Treatment itself can lead to impacts on cognition and their coping skills, disordered behaviors. I think what's important to think about in treating mental health concerns in pediatric oncology patients is that they're going through all of this at such a pivotal time of change. There's great physical, behavioral, and social development happening at this time. As I think as a practitioner, a little bit of the difference between how I would treat a pediatric oncology patient versus someone in the community is the really big need to incorporate the family at this time. And something to note that while many kids will struggle, most won't meet full DSM-5 TR, which is our diagnostic Bible, criteria for diagnosis, meaning they're not always reaching a clinical level. So I think we expect some anxiety and sadness, but we don't expect it to become something that may be diagnosable from a mental health perspective. So I wanted to think about kind of big picture strategy for coping. And I am a CBT therapist, so that stands for, it's our affectionate term for cognitive behavioral therapy, where we believe that there is a connection between our thoughts, feelings, and behaviors. So the interpretation of events may change how we feel and our physiological homeostasis, which then may impact whether we choose a maladaptive or adaptive behavior. So just in terms of thinking through that, you would try to use those foundational underpinnings of the developmental stages to kind of tailor which coping strategies you would pick for your child. In regards to feelings, know that all feelings are valid and acceptable. they can change, or we can expect sadness, anger, and sometimes even happiness and joy. I think it's totally fine to laugh sometimes when we're on the floor. That's okay. Think about how feelings are going to change our physiological experience. I know when I get angry or nervous, like right now, my heart is pounding and I'm a little fidgety, maybe a little sweaty. So I'm trying to be up here, taking some deep breaths, calming down my heart rate and my breathing rate so that I can think logically and pay attention to these slides up here. In terms of our thoughts, we want to try to help our kiddos catch and reframe their thought traps that they might fall into. So things like cancer is my fault, that's something that we can say cancer is nobody's fault. And then in terms of actions, be thinking about routines, schedules, and engagement in pleasurable activities, even on the hospital floor, to keep us feeling good. But that was a lot of psychology jargon, so I want to give you some tangibles of what you can do to help your kiddo going through this. So things like creating a journal or an art journal from start to finish, joining support groups. I think there's something really special about having someone who walked a mile in your shoes. Practicing deep breathing and progressive muscle relaxation daily, meditation. You can see many options on here. And I have a clock, so I'm going to pay attention to my time. And then how to support parents. So I think my biggest feedback to everybody is that no support is the worst support. So I think a lot of times we worry if we're going to say or do the wrong thing, but I think in that it creates fear, and so we pull back in terms of our support. I think that's true of all of our staff sometimes, and even our oncologists, of when to know when to enter a room, when not to enter a room. People usually want to see us and not feel alone in this. But I will say there's probably two things that are not the right thing to say. I think one is everything happens for a reason, and two, that it's insert your deity of choice plan for all of this. But other things you can do: honor the journey, especially how long it is, validate their emotions, recommend readings, allow for boundaries. I always talk to families about how people in their life unexpectedly might pull back, and to ahead of time let them know what they're going to need, and encourage self-care. It's that old saying of put your own oxygen mask on before assisting others. And some tangibles for parents too. So for those of you who aren't familiar, a Caring Bridge blog is a place where you can go in and write updates and share with a group of people, different than Facebook because you can more so choose who's coming in and out of that. Join support groups, find resources through your social work team, create a meal train, and discuss boundaries early. So to summarize, consider where your child is at developmentally to better understand what's going to be impactful for them and what their needs could be. Coping skills are like any other skills. They need to be practiced in order to be effective. So if you tell a child to take a deep breath when they're angry, we all know that doesn't work. If they practice it daily, it might work a little bit better. And that the impact of cancer on an individual is largely unpredictable. So one thing we do know, if your kids struggled with emotional or behavioral dysregulation prior to diagnosis, they're probably going to struggle with that during. And then real quick, just because I'm a psychologist and it's 2022, I wanted to make sure everybody had the most up-to-date mental health resources. 741 is one of my favorites, and then 988 is a new emergency line that starts on the 18th, not the 1st. They changed the date. But there's some things up there for you. Thank you so much.
Thank you. We're going to do questions at the end of the panel, and Dr. Sexton is next. She'll be doing this virtually. Okay, Dr. Sexton, we're ready to go.
Right. All right, were you going to put my slides up? All right, well, I'm hoping that you are seeing my slides. So
We can see
what
your
I was going to talk about today is, yeah, I see it now. Thank you. So the management of cancer symptoms and treatment-induced side effects with cannabis or cannabinoids. So first I just want to talk about this endocannabinoid system and how it is a system found in every tissue in our body that has been described as one to provide that we eat, sleep, relax, forget, and protect. Okay, you can go forward. I don't have any disclosures. Next slide. So this historical use of cannabis has been documented from ancient times in civilizations across the world. This is from a Materia Medica in 1865, I believe. It was given specific indications for marked nervous depression, insomnia, sleep disturbed by unpleasant dreams, painful conditions, and described as producing an agreeable semi-delirium, taking on the character of a sense of well-being and exhilaration. And so it's this well-being that is a piece of what we're going to talk about today. Next slide. So there are some pharmaceutical cannabinoids on the market. Marinol was approved by the FDA, and that is just a THC molecule. That's one of the main compounds, active ingredients of cannabis. There is an oromucosal spray called Sativex, which has not currently been approved, but is in the process of FDA approval for spasticity and multiple sclerosis. There is another synthetic analog of THC called Nabilone. And then there was a different type of drug that was tried to bring to the market, and the FDA did not approve it, which was the opposite action at the cannabinoid receptor of THC, which is antagonizing that receptor. But it was found to not really be safe for mental health to block that receptor. So when we're talking about cannabis, we're really primarily talking about the two compounds, THC and CBD, even though you may hear about a lot of other compounds. We don't really yet have good, solid clinical data on what the therapeutic utility or dosing of those other cannabinoids is. Next slide. So there are several potential roles for palliative care, and this was from a review in Current Oncology in 2015. You can go to the next slide, yeah. That, again, using cannabis could provide a mild euphoria or sense of well-being. So people who are sick don't necessarily feel high like recreational users might express, but they may just feel more normal. It may help reduce their psychological trauma. It helps to enhance sensory perception, so increased appreciation of food, which is important for cancer patients, and just to heighten the awareness of moment-to-moment presence, kind of allowing the patient to kind of shelve all of their trauma, their pain, everything around the cancer diagnosis, and just move on with life. Next slide. So there's a good rationale for using cannabis for appetite, and this is that this cannabinoid receptor is in the parts of the brain that help to regulate and control our food intake, our motivation to eat, the reward pathways. It's been shown to be an effective antiemetic and appetite stimulant, and this has been shown in animals, and this compound AEA is our natural endocannabinoid. And when that compound is given to mice, they get hungrier. And so Marinol was brought to the market specifically for this purpose during the time that the AIDS epidemic was occurring back in the 1990s. And so many recreational cannabis know well the effect of the munchies, and this is what we sometimes see cancer patients benefit being. Next slide. So chemotherapy-induced nausea and vomiting. Again, we've got these cannabinoid receptors both in the periphery and in the gut. And so there was a test between ondansetron and dronabinol, which is the THC pharmaceutical version. Only 10 to 15 patients per arm. They saw similar effects between active treatments. And so it was thought THC could potentially be a good way to address this loss of appetite, with both nausea and vomiting, because, yeah, keep going. So yeah, so the loss of appetite is another reason people may want to use cannabinoids. There was an open label trial in 1994. There was another 2002 study that was 469 patients where they compared dronabinol with megestrol acetate. And they didn't, the THC compound really did anything better. They both kind of acted similarly. So the data is not real strong in favor of THC, but other doses, this was twice a day dosing, multiple dosings per day, other doses haven't been explored. Next slide. But you can see that the American Society of Clinical Oncology, the Comprehensive Cancer Network have said that they only approve or recommend this dronabinol compound if the patient has been resistant to other standard antiemetic therapies, and that the current evidence to replace an FDA-approved version isn't very strong. And we have that data, and then we have patient data. Some patients seem to benefit from it, others may not, similar to any drug. People is which cannabinoids might be good was not found to alter anything relating to sleep architecture, but THC has been found to do that. You can go to the next slide. And so we do sometimes see patients that may substitute cannabis for other drugs that they might be using. Individualized, we don't have strong data yet to say that it has a strong effect on sleep. And the next slide. Another thing that cannabis could be for is effects on anxiety. And so there's sort of this paradoxical relationship, because a lot of people anxiety or panic attacks. But if you go to a lot of the survey data around cannabis, one of the strongest motivators that people report they use cannabis anxiety. And so what we know is that there is like what we call a biphasic effect, that it's dose related. If you get a high dose of THC, it can definitely promote or cause anxiety or paranoia, but at low doses, it actually may be anxiolytic. Next slide. And so these are, and hit the forward button, showing these are different studies, how many people were in each study, the year they were published, what percentage of these surveys of the people who responded said that they found anxiety benefit from cannabis. So, around 50% if you average all. Some of these studies, they substituted that. So again, this could be dependent. And next slide. And it could really, because of the medical trauma surrounding diagnosis and the PTSD that can result from that. And so, hyperarousal, with cues, they don't do doctor visits, see doctor reports, intrusive thoughts, nightmares, and similar to other forms of PTSD, cannabinoid receptor 1 agonists, which means THC, has been shown to suppress this type of anxiety and aversive memory. And so again, this can be low dose THC. Just brief on, I think it was in the 1970s. These were some placebo-controlled studies done at dose 20 milligrams. So these are actually to actually use clinically, specifically in cancer patients, may even be very sensitive to THC. So I would probably never use this dose. Next slide. They did a randomized controlled trial. This was in cancer patients and found that it could be a useful add-on analgesic. Often opioids are still going to be the gold standard for pain control in cancer. Next. And then the other type of pain that patients may develop is chemotherapy-induced peripheral neuropathy. So again, these cannabinoids acting at the glial cells, the supportive cells around the nerves, may help with sensitization to pain, and so really helping turn the volume down on pain. And the next slide. This slide is just to really reiterate what I was saying about dose. So this is a dose response curve that showed that actually higher serum levels of THC were correlated with increased pain compared to baseline. And so these were people with diabetic peripheral neuropathy. They were given the opportunity to inhale cannabis vaporization, and as they increased the dose of the cannabis, their pain benefit actually reversed, and they did not get the pain benefit at higher doses. Next slide. So I just wanted to mention this book, Dying to Get High. Wendy Chapkus, a social researcher, interviewed people with cancer using cannabis, and they said it gave a present tense focus. They did not, this patient didn't feel it was altering so much as enhancing life in the context of terminal illness. It produced a positive shift. It stopped the fear, it stopped the worrying. And one patient said, I don't think there's anything wrong really with trying to dull the reality of my situation. So final slide. Cannabis has long been documented for use in alleviating anxiety. Again, this is at really low dose THC potency. And then at low potency THC, and there's many of these types of products available now, that a conglomerate of symptoms that patients are dealing with may be able to be addressed with a single botanical medicine. And that's the end of my show. Thanks so much.
Hi, good afternoon. Let's see if I can advance this. My name's Janelle Fulbrick, and it's my pleasure to be here. I've enjoyed meeting the people I've gotten to meet so far, and I'm looking forward to sharing a little bit about care of adolescents and young adults. I can't do that without, going too fast. Nodding to my team, it is not something I can do alone, and I'm partnered with nurses and rehab specialists as well as other psychosocial providers, child life specialists, social work, all that. And what I'm going to talk about is I'm going to talk a little bit about who is an AYA, because that can be confusing. There's different definitions. What my adolescents and young adults, at least at City of Hope, have said they're distressed about, and then what we're trying to do something about it. So first, who is an AYA? Some research. Well, there's some of our lovely patients who said, yes, put us up there. And some of those who are osteosarcoma survivors and gone on to go in healthcare. AYAs, in 2006, there was some research on success and outcomes. How far have we come with treating cancer? And they looked at different categories of cancer, and they looked across ages. And not 100% consistently, but pretty consistently, people between 15 and 39 weren't showing the same gains in outcomes. So that's that group where you see that dip down there. Those people aren't getting as much benefit as advancements in science. So since then, there's been a lot of research and efforts towards this group that we call AYAs, which even though a 15-year-old is totally different than a 39-year-old, have in some places gotten grouped together. So there's been reports put out, journals developed, NCCN guidelines, so that the nice thing about this is that not just people at comprehensive cancer centers, but hopefully young adults treated anywhere will have access to these guidelines. So that's what an AYA is from an oncology definition. Now, what are AYAs distressed about? We did a little bit of research to see if AYAs were more distressed than peds or older adults, and that research isn't pretty much yes, but it's complicated. It's AYA males. That was a surprising finding, that are the most distressed. But what is distressing? I mean, it's a developmental stage. We haven't gotten our traction yet in life. We haven't defined who we are. What's distressing us? And we first pulled data on our screening tool at the beginning of treatment. Honestly, probably not the best time to do a screening tool. You're just in shock. I call that the whiplash phase. And I have my notes here that kind of summarize that. A lot of, first, financial toxicity. How's this going to impact me financially? Side effects. How's it going to impact my life? And I'm depressed or anxious. Help me out with that. So those were the concerns. But then we turned around later and we said, well, what about people later on in treatment? So we did this screening in our peds clinic. City of Hope has adults and pediatrics, so I can capture AYAs from both sides, which is really exciting. And so we did the peds and head and neck clinic, and the script flipped. So when you look at people across treatment, worry about the future now pops up, and then we still get some, a little bit of fatigue, but then the emotional has risen from the bottom to the second. Side effects are still right up there. And then we have, how's this going to impact my life? But look at how my family will cope. How my family is coping is a big issue for young adults, along with the ability to have children. And then finances has dropped down to the bottom. So this beautiful piece of art was done by one of my young adult patients that did the early stages of teaching me what young adults needed. And she was a brain tumor patient, but she did this beautiful piece of art to demonstrate how she was able to grow and blossom with adequate support. And that was family support, that was physician support, that was the psychosocial team support. When she came to me, I was getting a lot of young adults in my clinic, and they were coming up with a lot of the same kinds of questions and concerns and issues. And I said, there's got to be a more efficient way to help people out. Just this one-on-one hour-long psychotherapy, I can only do so much of that a day. What can we do to address this better? So over the past 10 years, we've been developing interventions, and one of them is what we call our toolkit, and it's educational resources. It's like AYA educational resources all in one place. It is kind of Little City of Hope is specific, but it has a lot of links to resources like scholarships or First Descent or some of those great programs that you guys probably are well aware of. And it's available on our website. So go City of Hope, AYA Toolkit, you can use it. We don't want to hog it. We started social media, both to kind of keep things light, have a place where people can connect, and give some blasts about what might be coming up in the future. And then we started a peer-to-peer connect program, kind of like Emmerman's Angels. Maybe some people know about Emmerman's Angels, but it's like local to City of Hope. So it's like, okay, but you get me when we're talking about this doctor, or when we're talking about this program, or the COVID restrictions. And so we have about 60 people enrolled in that right now. And then finally, okay, support groups. My young adults say, oh, support groups. I don't want to go to a support group, because they want to support people. They don't want to be supported. So we didn't develop a support group. It's an education and peer connection group. And what we did is, I'll show it on the next slide. We took both information from the screenings, information from our young adults. We asked them questions. We looked at the literature. And they said, well, we want more information in these areas. And so it was communicating with my physician, navigating, bargaining, like it sounds like Mia has done a good job of with my physician around quality of life issues versus treatment issues, right? Coping skills, Symptom management, self-image, body image, super important. Never feel guilty about that being an important thing for you. And relationships with my family. I was in college, now I'm at home, I need some space, they're in my hospital room all the time. Relationships with loved ones. So those are the kinds of things that we did in this group. Now we studied this one because we wanted to see, one, could people come? Did they like it? Did it work? And so could people come? Well, this is pre-COVID, so it was a little complicated. We did get people to come. In our catchment area, we had a large number, a population Hispanic, and then, so that was about 50%. We had about 25% Caucasian, and then a lot of different other things. And then the diagnosis, we had about a quarter that were solid tumor, and these were almost all osteosarcomas. They were not breast cancer, they were not lung cancer, it was almost all osteosarcoma. Maybe a few Ewings. And why they couldn't come? Transportation. I mean, if somebody has to bring you to the hospital, they're not going to take back off work when they were already there on Tuesday to bring you back for a group on Thursday, and you don't want to come anyway because you sort of don't want to be there. You want to be doing something different. For the inpatients, a procedure. They felt like crap. They were in isolation. Their counts were too low to hang out with other people. And then finally, there were the people that, like, groups are just not their thing. Like, I don't want to be with other humans. I just want to be by myself. And that is not dysfunctional. That's just our personality style, right? So you can kind of see that we had the membership. We had one person that could come every time. 5 only came once. Now, we looked at their anxiety and depression scores, and 41% were above clinical cutoff, which meant they had significant anxiety and depression. Anxiety and depression went down as they went to the group. It wasn't correlated with how many times they went, just with going. And so while doesn't definitely say that the group had that impact, it was enough that, boom, COVID hit, and we decided, well, let's continue this. Now that COVID's here and the hospital has figured out how to do televideo, we started doing it televideo, and membership exploded. People attended from their cars, they attended from work, they attended from their beds. They said, hey, you need to have more sessions, and they need to be on this cognitive concerns and survivorship, and they started then meeting together on their own. They started supporting each other, which was the best thing. So that's pretty much it. There's more stuff that we want to do, including having a young adult clinic, but that's what we get to do right now to support our young adults, and I'm so glad that I got to share about it. Thank you very much.
How we doing? Almost done. Oh, thank you. I think I should have some slides coming up there.
You may want to advance.
Oh, just advance? There I am. Good afternoon. I'm so incredibly humbled and honored to have been invited to participate in this really meaningful conference. It's my first time. I hope it's not my last, and I just really am in awe of the dedication, the passion, the commitment to patients, families, all the clinicians and researchers that have gathered here in beautiful San Diego. Thank you. I am a clinical social worker at Children's Hospital Los Angeles, and I am very proud to have worked for the last 15 years alongside incredibly dedicated physicians, nurse practitioners, and others to provide long-term follow-up for cancer survivors and their families. The brochure on the left is orange. That is our program, the Life Survivorship and Transition Service. The brochure to the right is our transition program, and I'm going to talk a little bit more about that program in detail as we go along. But just so you know, that I am coming to speak about survivorship and transition because they are inextricably linked together. In our program, we see about 36 to 40 patients each week, including 8 new survivorship patients. Those are children and adolescents who come to this survivorship clinic for the very first time, generally about 2 to 3 years off treatment. Some patients are held on to a little bit longer by their disease team, and increasingly we are doing what's called concurrent care, where children and adolescents off treatment may continue to see their primary disease team while getting their feet wet and coming to survivorship to start learning about late effects and to learn about what they can do to take care of themselves to be healthy young adults. Our clinic is every day of the week except for Friday, which includes each visit. At each visit, each survivor is seen by a physician, a nurse practitioner, and a social worker. Our new patients are also evaluated by an occupational therapist, which is new for us. We also have research coordinators and registered dietitians available to us as needed. This graphic is a little misleading. We all know that the cancer journey is not linear. What's not in this slide are relapses, are secondary malignancies, but generally a patient is diagnosed, they go through treatment, off treatment, and then to survivorship, and then ultimately transferring to adult-based care, especially if they are treated in pediatric centers. Transition is built into all of this, right? We transition as human beings, we transition as patients. You know, it's just all a part of life. So we try to provide our care at all these different stages, and within this care is embedded the idea of transition planning. We include patients in conferences when it's appropriate. We interview patients alone, starting about the age of 13, to really help them formulate questions and get answers to what's going on in their bodies. We do high-risk screenings because we know that cancer doesn't happen in a vacuum, and we have kids dealing with everyday struggles and risk-taking behaviors and concerns about relationships and school, so we really do address the whole child in all of our evaluations that happen annually. Again, just to reiterate, the survivorship program generally starts to take patients at about 2 to 3 years off treatment, and then we follow patients until about the age of 20 at Children's Hospital. If folks are diagnosed a little bit later, we won't transfer them to adult care until they're at least about 5 years off treatment. So I get this question a lot, and I'm sure many of you in the audience do. When do I call myself a survivor? Well, that's a decision that each patient has to decide for themselves. Some people will identify as a survivor the minute they're diagnosed. They're still living and breathing, and they're just beginning their journey. Others may decide to wait until they're finished treatment. Others may wait until they're 5 years off treatment, 5 years from diagnosis. It really is an identity that needs to be explored and embraced by that individual. I would also posit that our family members are survivors, our brothers and sisters and moms and dads and neighbors and grandparents. You know, cancer is a family condition, and everyone is impacted in the system that can be so, just provoked and disrupted at any stage of the journey. So we do present the Beads of Courage at Children's Hospital Los Angeles. I'm sure many of you are aware children and adolescents can receive beads and different symbols when they complete certain types of procedures and treatments. The long-term follow-up clinic offers the survivorship bead at that first visit. So when we're talking about survivorship, we're not just talking about illness. We're talking about the trauma that goes along with witnessing and making friends and having friends not do as well than maybe I'm doing. We're talking about the strain on the family and interpersonal relationships. As I mentioned, families are systems, and when one piece of the system is, off kilter, then that can definitely have an impact on every part of that system. Financial problems and job stress are very real. I don't need to really say that to this room. There was a great Kaiser Health News investigative report offered on NPR this week that talked about medical debt and the unseen medical debt of loans and credit card debt building up, as we know that our healthcare system is woefully inadequate to cover the significant costs of rising healthcare. So again, educational and social disruptions, that's missing out on first days of school, soccer practice, first dates, those kinds of things. So it's not just, again, the cancer and the treatment that is survived, but also sort of living through childhood with incredible stress is something that is to be survived. I'm just going to skip over this briefly. As my co-panelists already alluded to, the anxiety, the depression, and post-traumatic stress, those are something that we screen for at every survivorship visit at every year. We know that the cognitive changes which affect learning can be incredibly stressful. We know that many treatments cause fertility problems. We have growth hormone deficiency. We have new late effects that arise as a result of treatment. Those are all the things that we assess for at every visit. The flip side is post-traumatic growth, and that's not to really fall into that old cliche of there's a silver lining, but there really is. Going through difficult times can and oftentimes does build resilience. So there's a learned resilience that we see in children, adolescents, and families too, as they learn to navigate really stressful times and not always, but many times succeed. Again, these are some brief strategies for coping. We strongly encourage, just a lot of insight and development and self-awareness into the types of emotional care that's needed. We encourage opportunities for social support. We review basics such as good sleep hygiene, the importance of nutrition and exercise. As Dr. Baker alluded to, the mindfulness-based practice that can be so incredibly helpful for not only dealing with the day-to-day stresses and anxiety coming to the hospital for scans and blood work many years later, but just, the day-to-day stresses. Spending time in nature has been shown to be incredibly powerful as well. So just a quick overview. This is what we do in our long-term follow-up clinic. We provide risk-based screening for the potential late effects, chemotherapy, radiation, surgery. We provide lots of education. We encourage health promotion, and we provide the tools so survivors can learn to be good self-advocates. We create partnerships with PCPs and really encourage getting back to see that primary care physician every year, getting caught up to date on vaccinations, things like that, and we refer to an incredible team of specialists within Children's and beyond. And we also then prepare for transfer to an adult medical home. Again, transition planning happens very early on at all levels. It's about teaching kids how to speak up, how to get their questions answered, how to participate in consent conferences. Cancer is a chronic health condition. Just like if someone was living with asthma or diabetes, there are little things that you have to learn to take care of yourself, but with lots of guidance and good tools at your disposal, the transition planning can be successful. And I just wanted to reiterate too, transition planning is not necessarily the same as transfer of care. A lot of times they get commingled. Transition planning is a concurrent process that happens throughout treatment, and transfer happens generally at age 18. These are some of the tools for transition that we encourage our families to learn about. The COG offers survivor guidelines, which is what our survivorship care plan or life clinic summary are based on. Cancer treatment summary should be available through a patient portal if that's an option at treating institution. We also really focus on some of the transition readiness skills by using the track, and I have copies of that if anyone would like to see it. I'm out of time almost, but quickly, this is our model. We do transition our lower risk patients to primary care. Higher risk, most of our osteosarcoma patients do transition to our program at USC Norris Cancer Hospital. For patients that live out of the area, or if insurance doesn't align with what's offered at USC, we have other partners in the community. We have begun to refer to programs at UCLA, City of Hope, etc. I have several more slides on resources, and I'm not going to have time to go over them. But again, there are oncology camps. First Ascents was mentioned. Elephants and Tea is a wonderful AYA resource for connection and storytelling. We provide a lot of education around future planning, educational assessment, vocational planning. We teach about the ADA and ways survivors can get accommodations at work and at school. and then link with resources such as the Department of Rehabilitation, Social Security as needed, and also for folks with intellectual disability, the Regional Center is a great support for our residents of California. And finally, long-term planning. This is something we all need to prepare for, whether or not we had cancer. Do we have an advance directive? Do we have a durable power of attorney? Who do we want speaking for us if we can't speak in that moment? Special needs trusts are a great resource for families that need to save up for future needs. And I think that's about it. And I have some references there for further reading around survivorship and transition, and of course the pediatric psychosocial standards of care are required reading, I think, for everybody in the room. So I would encourage you to check those out if you don't know them. Thank you.
Thank you, panelists. I mean, I think the moral of the story here is it takes a village. And as oncologists and surgeons, we can't do what we do without the help from all of you. And that is both the journey through diagnosis, treatment, and recurrence, unfortunately. So I'm going to open it up to questions. Don't be shy. It's a great opportunity for patients and families and clinicians to step up to the microphone. So if anybody has questions, please. Oh, he's got the microphone back there.
Hello. I guess my first question is for Dr. Folbert. You mentioned that for AYAs that there has been less progress over the past few decades in cancer treatment. Do you have any hypotheses for why that's the case?
So fortunately, we have made some gains since that time in 2006. But and you guys chime in because you might know too. Some of it is, and that might be the experience of some of the folks in the room. When we're an adolescent or a young adult and we have an ache and pain, we don't necessarily think that something's wrong. We think we worked out too much, or we think that I just played soccer too hard, or I shouldn't have done that jump in gymnastics. And so there's a diagnosis late sometimes. There's also insurance, at least back in 2006 before things changed a little bit more and the length of time you could stay on your parents' insurance changed. That impacted things a lot. And then there's probably a little bit of a certain degree to which primary care providers just didn't think of something that serious as being a possibility when you did go to a provider. So those are some of the things. There's also some challenges with, I think another factor was once you are an adolescent or a young adult in the system, sometimes, especially young adults, maybe you're in college, you wait to get diagnosed because, well, see, I have this theory. We have ups and downs in terms of diagnosis, and it seems to happen right after school lets out and right at Christmas break. We get tons of diagnoses. People are waiting until it's convenient, and so there's a little bit more of a wait. And that, it's just natural. It's just, you don't expect that this is going to be what's going to happen. And a young adult, once they're in the system, sometimes it takes them a while to kind of know how to engage it, how to interact with their doctor. They might have different values or priorities for how to spend their time than their doctor does. And so sometimes it takes a little while to navigate that. I've also seen young adults that I've worked with have wanted to partner with their doctors. They don't want their doctors to say, you need to do this, 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 and this. I can't tell you how many times I go to a hospital room and the nurse is like, well, she needs to take her meds. And I'm like, we can tell her the risks and benefits, but she gets to choose. And that has developed over time. And so I think sometimes there's some push and pull in how people communicate that can result in that too. My other colleagues will tell you we didn't have protocols for young adults. We either grouped them in the pediatric or in the adult when really they needed there was a better way to treat that was specific to that age group and that developmental level. you can probably, Dr. Fetterman can probably speak better to that. I can just speak to more of the psychosocial stuff.
And the other thing I'll say is that the biology is different in some of these cancers. So, for example, a 23-year-old or 25-year-old with ALL will not do as well as a 10-year-old with ALL. And less AYAs enroll in clinical trials. Some patients will actually do better treated in a pediatric institution versus a medical oncology institution. For example, leukemia is probably the best example of that. So there are some inherent differences specific to the disease and the age group. Other questions? There's one back there.
So yeah, I have a question for Dr. Sexton. Is she still on the call? Do you guys know?
Yeah, she should be on the call.
Okay, awesome. All right, so correct me if I'm wrong, but it says that in your slides it seemed to suggest that after a certain amount of THC, there's a sense of diminishing returns in regards to alleviating pain. So with this in mind, do you agree with the current standard of the distribution of medical marijuana? Because in my knowledge, all someone really needs is a med card, and they can begin purchasing large amounts of this substance. So do you think that this should be more regulated, maybe like a bigger conversation with the doctor, or do you think this should be changed in some way, or do you agree with how we're doing it?
That's a big question. I mean, I think there are some improvements that need to be made, particularly, for the therapeutic or medical use of cannabis, because, I think what we're learning as clinicians is that the dosing for, recreational use or just wanting to get high is very different than the dose that might actually be efficacious for, what we talked about, appetite, pain. So yeah, I think your point on when you say about the diminishing returns with higher dose. What higher dose will tend to do with any drug is to downregulate the receptor or the system. And this can happen with cannabis as well. And we need a healthy functioning endocannabinoid system. So it'll take a while to get there. We need a lot more data, but it would be great to see truly separate systems and different types of products that are more well suited for medical use.
Okay, thank you.
Dr. Mascarenas in the back.
Hi, this is Leo Mascarenas from Children's Hospital Los Angeles. I too have a question for Dr. Sexton, and that's again related to the use of cannabinoids. I mean, most patients with osteosarcoma are usually treated with cisplatin, doxorubicin, and high-dose methotrexate, and those are treatments which cause a lot of nausea and vomiting, and they're in hospital so often getting these treatments that weight loss is also a big issue. And we know that cannabinoids can help with nausea and vomiting, can help with increasing appetite, and can help with a sense of wellness, and there may be some effect on pain. However, just the previous question also said a lot of this is not regulated, and then there is a lot of theories of this sort of anti-cancer effect of cannabinoids, and we all know that one cancer is not the same, and in this room, not all the osteosarcomas are the same. I mean, we really know that it's a big spectrum of disease, which we just use one word for. There's also emerging data where cannabinoids can sort of interact with newer therapies like immunotherapies, like for example checkpoint inhibitors, and make them less effective in patients with cancer when you actually take these drugs. And we are at a point where we really want new therapies for patients with relapsed or refractory disease. So are there efforts where drug interactions are being studied, and is there an opportunity, for example, like in California, we can track opioids really very, very closely Are there any efforts to bring cannabinoids and such into a similar system, so at least there are opportunities to check for drug interactions and advise patients effectively?
Well, you make a lot of very good points. As far as what is being done, I think with the federal status of cannabis still being Schedule 1, it's a huge impediment to being able to do anything with regards to really digging in and studying the therapeutic potential. And part of the problem is the inability to access different types of preparations. So our federal government has really only provided inhaled cannabis, and the federal government has made some new licensees recently who are trying to bring some new products to researchers, but this is still going to take years. And to your other point about tracking, I think that's a huge problem because of the federal status and the Schedule 1 status that many of the recreational users who are out there they don't want to be tracked. They're afraid that the federal government is going to come after them. So it's a very touchy subject. So I think the best that we can probably do is individually within institutions set up registries perhaps, and that's what we've done within UCSD. Now that we have a clinic where patients get sent to me for advice on how to do their dosing, because they're going to get absolutely incorrect advice at the dispensary level or from people who are enthusiasts. And so that's what we're doing right now, is setting up a registry so we can track this. And the only other thing I wanted to address was the drug interaction potential. This has mainly been demonstrated with very high dose of cannabidiol. So this has come to light from the new FDA-approved drug Epidiolex in pediatric epilepsy, where they were giving children up to 20 milligrams per kilogram, and they were on other drugs, other anti-epileptic drugs. That said, probably our older patients, may be at risk, but yeah, there's still a lot we don't know. But personal experience, clinical experience, is that at the low doses that really are therapeutically beneficial, there is very low risk for drug interactions.
Thank you. I mean, this is more of a statement than a question, and that is that I think as oncologists and healthcare providers, we are underestimating the number of patients that are using cannabis and cannabinoids. It's oftentimes that I find out after we've completed treatment that that's how they survive treatment. And so I do think it behooves us to be open with our patients and also not that we necessarily know how to guide them, but get them to specialists like Dr. Sexton that do know how to guide them through dosing, formulations, et cetera. Other questions?
No other questions?
One question. I think this is something close to my heart and all of you here, is that the AYA community and osteosarcoma especially has, they're very tight. They're tight in our institution, they're tight here. And what is the guidance that you give to both patients, families, and oncologists when a member of that community passes away? And that's been something, I don't know who would be best to answer that. Maybe Dr. Folbrecht.
Institution, they have been doing lots of activities on the floor. They're very tight. It is a source of a lot of grief.
Could you pull the microphone a little bit closer? We're having a hard time hearing you out here. Thank you.
It is a source of a lot of grief. It depends on the patient, it depends on their relationship, but we try to be very open about it. We try not to hide things, we try to answer questions, keeping their medical information and the sensitive information confidential if that's it's still needed in that situation. But we've also developed a grief program, and we provide that open to everybody. it's not just the patients, it's also the nursing staff and the psychosocial staff. We have Tea for the Soul. I missed yesterday, I'm totally bummed by this, I missed puppy therapy for the nursing and psychosocial team. They got pet therapy. We try to be open about this. We try to talk. We answer questions. We all have. We don't really necessarily have any one-on-one strategies. It depends on our relationships with the people. A social worker might know that person better. I might know that person better and be able to answer their questions. It's really key to get out their fears too, and make sure that if this is triggering a lot of fears for them, that we can address that. We can help them address that with their physician. And then I always give people the opportunity to think forward with it. How if they're in the same situation, how do they want to do things differently? What do they want us to know for them? So we try not to shy away from that, because then that just communicates that we're uncomfortable with talking about it. And we instead want to have, an openness to it, and then refer on if there's some serious issues with regard to that. If it's that grief is impacting treatment or severe mental health issues, then refer on for more treatment.
Great, thank you.
So
You got to get right up there on it.
I think it's really about, as you said, just really honoring the requests that the patient may have outlined prior to their death, if it was something that was imminent, as well as the family. And there are such close relationships that develop over time that I think that word of mouth spreads very quickly. And I think just having a space available for young folks to get together, whether it's online, whether it's in person, whether it's through attending a camp or another support programs, activities, I think that those ways that folks can support each other just are very varied. And I would encourage institutions, practitioners, and families just to consider all the different forums where that support can be met and managed.
Thank you. Well,
And one other question. First, thanks for this outstanding presentation, and I'd be honored to work with any one of you, and I wish I could. But I would like to know how in your respective institutions you pay for it, and that, your outstanding services, how can we ensure that that's available to the patients who are in need? I think that's a problem in New York for sure, and here in California, I imagine.
I'm down at Rady Children's Hospital, and we're paid through from a foundation. So we have the Celebration of Champions that happens every year, where they're able to raise a lot of money to be able to pay our salaries. And so because of that, I don't have to do any billing, which means I don't have to submit to insurance a diagnostic code, and I'm not bound by CPT codes, so I can do whatever I need for the patient, and we're very fortunate for that.
Lucky. I got a bill. I've got to meet RVUs, blah, 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 blah stuff. I'm on the medical group. I'm paid by the institution. Most of the supportive care program is considered mission imperative, mission support.
Critical.
So mission critical. Yeah. Whatever. We're covered by the medical center part of the institution rather than the medical group, which that's probably getting way too technical. For the AYA program, I do a lot of fundraising. I do a ton of fundraising, and I have a lot of support in that. I have development program. The chair PEDS helps me. Sometimes the head of supportive care helps me. And we beg, borrow, and don't steal. Maybe we steal some resources here and there. We call it
You're a
teamwork.
chair, you have to do that.
But it's worth it. It's important.
Well, I ask, it's very important, and we've just surveyed our patients, and there are 20% who have significant things and can meet criteria, but when you can't meet the DSM code, then how can you bill? It's a problem. And I can't even get IRB approval for the interventional approach. And right now I'm hiring one of the psychiatrists on orthopedics in order to do this, because even institutionally they're not interested, and psychiatry is poor and not well funded, and so they think I am, and so it's up to me to do it.
That's really progressive of you, Dr. Healy. So I'm going to take that back to our orthopedic department. But I think to all of your points, I mean, this is a critical part of what we do. We can warp in and warp out as physicians, oncologists, whatever, surgeons, but without the support, we are nothing. And that's what our patients need. You know, at our institution, it's philanthropy. It's Teen Cancer America. I don't know how many of you know this organization. They started in the UK with Roger Daltrey and the WHO, and have come to the United States and have funded I don't know how many cancer centers, AYA programs. Excuse me. So that is an opportunity. And then, you know, the health systems really need to invest in this, because this is part of holistic care for our patients. So, but yeah, I don't have the purse strings.
I would just offer too that the psychosocial standards of care, there are being benchmark measures being developed whereby programs can go to their institutions and offer that if we meet certain criteria in providing psychosocial services, you know, it will add and enhance the reputation of the institution. So looking at what the gold standards are for psychosocial care, whether it's grief support, sibling support, support for school liaison and school advocacy programs. All those are built into the standards and are great measures that you can show with the research that the outcomes of having these programs can really improve overall outcomes.
Okay,
Thank you all. Sorry about that, Dr. Fetterman.
I was going to say we're over time.
We are.
Okay.
We have about 7, maybe now 5 minutes between now and the start of the next session. So if you guys could do a quick turn, that would be great. We're going to come back
Thanks,
to
everybody.
big data and biobanks. Thank you very much for the panel. Great discussion.